Hello, everyone, and welcome to today's live broadcast, Unlocking the Potential of the Laboratory Through Clinical Decision Support, presented by Todd Wharton and Katherine Metz of Abbott Diagnostics. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Abbott Diagnostics. For more information on our sponsor, please click on the Abbott logo at the left side of your screen. Now let's get started. I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click the Send button. We will answer as many questions as we have time for at the end of the presentation. Additionally, we will be conducting a few polls throughout the presentation, and we appreciate your participation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. The presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I would now like to introduce you to our speakers, Todd Wharton and Katherine Metz, both Abbott Clinical Solution Consultants. Additional information can be found on their backgrounds in the Biography tab at the top of your screen. Katherine, you may now begin today's presentation.
Thank you very much, Christy. Welcome, everyone. Thanks for joining. I'm going to begin by talking about this title page that you should be able to see clearly in front of you, and highlighting that while it's maybe an attractive picture of healthcare occurring, it's absolutely vital to us at Abbott to make sure that we let all of our customers know, and the healthcare system at large know, that we really value lab data and laboratorians and their role in the healthcare system. So this breaking through walls and bringing down barriers between the lab and the rest of the healthcare system, we think is absolutely critical. And that's really behind the theme of what we're here to talk about today with clinical decision support. Our objectives today, as you probably saw in the invitation, is to review the strategic imperatives that drive the need for clinical decision support, encourage a common language related to the clinical decision support process, and especially to encourage a broader participation in this process. So not just for the laboratory team and lab leadership, but beyond the lab and including everyone within the healthcare system, not just those that are in planning or quality assurance, for example. We'll be providing specific examples and applications of effective clinical decision support implementation, and talk about ways to select high impact projects that can effectively target clinical variability issues and other key initiatives. By way of background, I want to highlight some things that I think we're all pretty familiar with, but to really hone in on some of the real priority ones here that are common to us all. Some are positive, some are negative, some you might say are neutral or to be determined. The reimbursement cuts that we're all seeing, staffing shortages certainly create great challenges for us. Patient volumes are going up. In terms of new payer models or hospital consolidation, you might say those are neutral, maybe positive, maybe negative, depending on your market. But absolutely, the access to greater information is perceived as overall a positive, but a great opportunity and something that we're all striving to make the most of and to harness the power of that additional information. Further, the volume of diagnostic information has fueled the complexity and of clinical decision making. And prescribers, as well as other clinical team members, really have lots of day-to-day demands on their time. And so more locally, it's time pressure, the vast volume of information such as chemistry and hematology data that, according to one survey, each primary care physician each week has 930 pieces to process. And physicians who've got questions about what it is they want to test, how they want to interpret it. They've got questions that they're either not asking or they're not getting answers to. In addition, the presence of diagnostic errors has been an issue, and it continues to be a serious issue. Medical errors are considered to be the third leading cause of death in the United States. At least 1 in 20 adults experience a diagnostic error annually in the course of seeking health care. And diagnostic errors account for coming up to a third of malpractice claims and more than a third of total payments for malpractice. At this point, we're going to take a break for a moment and ask you to complete a brief survey, and we'll share the results with everyone. So there's a survey that should be appearing in front of you, and we're asking you to think about where you think diagnostic errors occur as they relate to laboratory testing. So we've got answers A through E. So where, even if it's in multiple places, where do you think the primary place where diagnostic errors occur as they relate to lab testing? During the clinical question, test selection and ordering, during sample collection, transport, and specimen prep, while the tests themselves are being performed, and then afterwards, upon validation, report generation, sharing results, or during the interpretation, reading interpretation, and taking action, that phase. So I'm going to give you a few more moments to respond. It looks like we have about 50 or so folks that have responded, and we're going to give you another moment here. Christy, should we go ahead and close, do you think? We have the responses slow down? Okay, and we're going to send the results so that you can see them. And are you all able to, I just want to confirm, Christy, I can go ahead? Wonderful. So as you can see from the results, for all of you that are participating on our call today, there are certainly a variety of places where diagnostic errors occur. And I think you're going to be happy to see that you're fairly close to what the literature says. Our audience is looking at more than a third of the time, it's during that initial ordering test collection process, heavily in the sample collection, transport, and prep, and then during the reading, interpretation, and decision-making process. I'm going to proceed with the rest of the presentation here, and you'll see that that's consistent, and although our results are even more dramatic in that regard. So most diagnostic errors truly do occur outside the laboratory. I think all of our lab team members and customers that are on the phone that are day-to-day responsible for high-quality, fast test performance, that job's getting done. It's getting done day-to-day, but it's really those things that are very often outside your control on one end or the other. That is where more attention needs to be paid to the quality of test results. This also reinforces the importance of lab being involved beyond the lab in terms of supporting how that initial selection, test ordering process occurs, at the end on how things are interpreted and how decisions are made, as well as the other stages in the testing process. I'm going to take a look now at what the C-suite, executives, CEOs, CFOs, and such, what their priorities are, and some literature and some data on what their opinions are related to lab. And the take home here is that, as you can see on the left, one key point is that lab is right up there with other key players in terms of the lab's importance in delivering key performance indicators. So they're important drivers, almost as much as you could say lab, but right there with finance, with pharmacy, a key component of delivering KPIs. And that the C-suite does have a specific does value the lab in providing specific solutions, and the C-suite has specific expectations of the lab to impact patient satisfaction, be a part of healthcare analytics and leverage that data, and participate in the test ordering process. So as I talked about in the very beginning, with moving beyond the lab and changing the focus and switching from a more internal, operational efficiency, lab production type of focus to more external and being more involved in strategic imperatives, having a seat at the table to drive initiatives throughout the institution. And we are going to be talking about some of the ways that the lab can participate and even lead in this process. So in this illustration, we're going to be talking about this brick wall in the center that might be perceived. And that is between, not always, but critically between physicians ordering tests and the physicians that are responsible for putting those results out there for interpretation and to take action. So, for example, on the left we've got very busy physicians that are involved with many patients at different phases of the care process, diagnosis to treatment, and they have a very limited amount of time. And on the right, we're representing diagnostic doctors such as radiologists, pathologists, and those that are putting out that information. And sometimes it can be perceived that there's a wall there. It's just receiving orders to perform certain tests, and you could say throwing the data over the wall. And we're proposing here that there is often a disconnect. Are the results and reports actually being seen by the prescribers and those ordering the tests? Are they interpreting the results properly? And are the results integrated with other information that the physicians are using in a meaningful way? And we would propose that there's definitely room for improvement there. And on the positive side, however, we can say that healthcare providers, or primarily physicians, really are allies to our lab partners and to laboratorians and lab leaders. They do want better communication and collaboration, and they want more detailed information. They want guidance as they receive these results. They want more consultation and additional interpretive information to help support the diagnostic process. And further, they have not a lot of training in lab tests, and a very small amount of medical school education is devoted to diagnostic testing and understanding the tests that they'll be receiving results on. So they want more training, and in addition on new standards, new tests that are available. So they're really looking for more support. So physicians are the lab's ally, and that's why we feel it's very important that chief medical officers and service line leaders be involved hand in hand with lab directors in looking at how best to leverage lab and other data to reduce clinical variability and reduce diagnostic errors, and really participate in these quality and operational strategic projects that are in place. So overall, we've been talking about a shift between the lab functioning as more of a cost center to a more integral part of creating value in the healthcare system. So I'd say the one word here I'd like to highlight is up at the top, so transforming. So we want to see our lab partners be less isolated and more integrated and more participatory in the clinical decision support process. And I'll also highlight that we do hear when we're speaking to our customers and health systems all across the country that EMRs are looked upon as kind of a be-all, end-all solution. But we're seeing that they're really not fully leveraging the lab at most institutions. And the approach with the EMR is really trying to tackle everything at once, and that results in not being able to be very nimble. It takes a long time, and it's lots of very large projects that can't always be modified as new clinical information and new guidance comes to the fore that we want to respond to. So what we're going to propose here is for us to think about what if you could leverage your current lab data as well as other lab data such as within the system to perform some of these things. So we're not going to go through all of these in detail, but the purpose here is for you to think about what kinds of projects that you're involved with, the tasks that you're called upon beyond test, lab test production that would have value within your institution. Because we really feel that labs do have power to improve test ordering interpretation, such as providing guidance and education and reminders in a patient-specific way to physicians and other team members. Decreasing clinical variability is critical to improve compliance with protocols that you already have in place and that currently exist but are just not getting enough traction. Patient flow and throughput increase means faster precision of data for decision making. And by gaps in care, we're referring to, for example, lack of follow-up on testing that's occurred, or needing better follow-up on patients who are post-discharge to help decrease readmission rates. Risk stratification and impacting value-based care is leveraging data to target key populations, such as with outreach. And then finally, all of you are within institutions that have current safety and quality initiatives in place. And lab is not always involved in those, whether it be to support those initiatives that are already happening by looking at lab data as well as other data sources. And we want to make sure that we foster that participation. I'm going to pass it over to Todd to continue with the presentation. And I'm checking to make sure, do we have any, it looks like we have a question about slide 6. So sorry about that, I missed that. I'm going to go back to slide 6 for a moment and look at the questions. So sorry about that, folks. And I apologize, I got to look in the right spot under new questions. And Christy, I'm actually not seeing it under new questions. So, okay, thank you. So the question here is regarding frequency. I understand the higher numbers in the pre and post examination. Can you comment about severity or consequences with diagnostic error? Well, I'll attempt to do that in just really giving some examples. So for, not just the frequency, but really what the impact is here. So clinical question, test selection, and ordering. I think the one that really comes to mind and that's the most prominent is, are the right tests being ordered? I know we focus, and many of our customers focus on too much testing, especially high-cost tests. So it's not just that, it's sometimes not using assays that are considered appropriate for current standards of practice. Let's say, for example, using panels where we could just be using individual tests to save money. So test selection is really critical, not just over-test utilization, could be underutilization and appropriate tests. And on the other side, in terms of how results are read, interpreted, and decisions taken, I think we can all agree that physicians have such a vast quantity of information to sort through. And if we can help them to focus on it and provide recommendations on now what? Is there additional reflex testing that we recommend occurs? Or in the actual results themselves, can we provide information on the reference or the source that this refers to? And help them understand the cascade of testing that might need to occur. So we want to make sure that physicians have information fast and the right information to support their decisions. And at this part, after the tests have already been released, and it's up to the docs to take their steps, we can definitely provide them with additional support that helps their practice. And Todd, I'm going to hand it over to you. I think I was on slide 11, and take it away. Thank you.
All right. Thanks, Katherine, very much. So I'm going to give you a little bit of an overview of the decision support tool and the opportunity that we have to impact your population at multiple points in care. We can help with patient flow, as Katherine mentioned, streamlining provider order entry. So if we really want to look at something like genetic tests, or you look at the redundancy in multiple alerts and clinical guidelines. But if we talk about genetic testing, it's a very costly test that multiple organizations need to perform, but how can we effectively look at the point of entry to really determine the appropriateness based on the diagnosis and previous tests that have been performed to really impact that patient flow and provide effective both effective care in the patient flow and cost-effective care as well. We can also help with risk stratification if you're looking at custom risk scores that you may be developing as an organization for opioid screening or any number of issues that you may want to address. We can also help, as Katherine mentioned, with care gap closure and looking at that within your specific disease states like congestive heart failure or diabetes, where we need specific exams and items that need to occur throughout the continuum of care. We can also help with, again, high-risk stratification and look at intervention and targeting specific patients for outreach and addressing factors within social determinants of health, because our solution is both data and vendor agnostic. So we don't really care where the data is coming from. We can process it into the solution, as we will discuss here in the future, and look at how we can help that to be addressed within your organization. Again, really helping the lab break down the barriers, not just clinically, but we can help you to address things along the financial continuum of care so that you can address your patient population before your claims are being dropped and really impact that care along your patient population. So how does it work, right? We're taking that data in from disparate data sources and inputting it into the decision engine. We're running it against organizational configured rules. And I think that really is a key component. A lot of folks out there are using different EHRs, and those EHRs are great at what they're able to do, but they're not going to be focused on how your particular organization is practicing medicine or how your particular organization is functioning as a lab. So we allow you to configure that so that every time a particular patient requires a more complex diagnosis or decision, we can apply the rule to that particular logic and analyze it against the relevant historical patient information, against those multiple data sources, and provide patient and organizational specific diagnostic information to help clinicians to get more accurate patient information and get high quality interpretation of results, again, with patient-specific treatment recommendations. So if there's specific cascades like anemia, coagulopathy, where they need more help from those diagnostic doctors that Katherine referred to in breaking down those walls, we can really help to bridge that gap real time and provide better information without forcing a physician to go into another system to gain information or to call another doctor for an interpretation. We can give all that to them real time in an interpretation that you'll see here shortly. How does the data flow work, right? All of you out there are dealing with more and more complex data sources. You're adding new instruments into your lab. Maybe you're transitioning to a new LIS. We talked about how our system is both vendor and data agnostic. So if you're going through a transition into a new LIS, we can transition from SunQuest to a Beaker or Meditech or Cerner, any of those particular systems, accommodate that LIS information, look at the historical data in both the LIS and the EHR, move into the second area where we would request an interpretation, look at the patient-specific results, and then put that feedback information into a loop that's going to build knowledge within the system, generate an interpretation. We can flag reports that need additional validation. We can also add reflex testing with patient-specific results and historical result data in there for that reflex. And we can also update the rule information real time. This can all be done without needing to reach out to your EHR vendor, without needing to reach out to us, and managed and configured by your organization internally. So some examples of rules and comments that can be created. As I mentioned, we can flag prior treatments or diagnosis, like the patient has a history of chronic kidney disease. How are we addressing that? What types of things may be occurring throughout the continuum of care that may be putting this patient in for additional information and looking at their renal compromise. We can remind a clinician of previous test results in real time. So they've had a previous impaired GTT. Do we need to look at their A1C or additional information? Again, provide additional context, and we'll look at some specific pathways on how we can do that. We can provide additional recommendations on clinical guidelines, looking at previous glucose levels, and as I mentioned, maybe we need to suggest an A1C, or perhaps the patient has had an A1C 6 months ago, but the clinician wasn't able to find that information easily. We can go ahead and do that very easily, and we can also remind the physician of specific test intervals as well. So additional workflow actions and things that we can implement. We can provide email or SMS alerts to members of your clinical staff, members of your laboratory staff, members of your revenue cycle staff to address patient-specific information. And as we discussed, we can automate reflex testing based on particular triggers and provide that workflow directly into the LIS. So we can go ahead and add particular items in the application as far as opioid enhancement as well, and how we're going to build out your enhanced opioid management. So some of the data points that we're able to configure and add into the system are a prescription history, the opioid metabolites, key terms from particular test fields. Has this particular patient ever been administered Narcan? What does their prescriptive history look like? What is their pregnancy status? Is there any mention of particular abuse? This is relevant in multiple points within the lab continuum. If you're trying to build out your outreach and you want to engage some of the pain management clinics that may be surrounding your organization, to go out and target them for better management of their patient population, and all of the opioid screening that they're having to do, we can impact that along multiple touch points in the continuum of care as you're looking at here. So if we want to look at the patient upon admission into the ED, if they're in a pre-op setting or post-operatively, how does this patient do with multiple different opioids? Have they refused an opioid prescription in the past? All of that particular data can then go in and affect outcomes to really increase your opioid abuse risk identification, look at prescription compliance, monitoring frequency and the need for perhaps more screening at those pain management clinics, or we want to just increase overall prescriber awareness of pain management alternatives. And really, if we can do anything as clinicians to help with the opioid crisis, we're going to be showing something positive to our organization. So really changing the way the lab is going to impact these patients across the continuum of care. But really what we're talking about here, as we said, is we want to break down the barriers and change how folks look at the lab. You know, I'm a former ER nurse, and I was always the guy at the other end of the phone who was calling the lab to demand my results faster, tell them that there was clearly no way that I could have hemolyzed a sample. But what we're talking about is really transforming the lab from numbers into action. So if we want to look at something side by side in a disease state like sepsis,
and how we address that as an organization. Everybody's clearly focused on lactate values, blood culture turnarounds, because these are things that our organizations are being measured by CMS on, and they haven't changed. So we can certainly get that number. Like in this slide, we can see in our particular example here, we have a lactate of 2.1. We're running a PCT, and that particular value is 36. So we can then respond with a solution in real time, giving the clinician information like the fact that our PCT is extremely high despite the fact that the lactate is near normal. We can also track your lactate times for those particular turnaround times like you may be interested in for your core measure compliance. But if we want to be more insightful, we can provide information like the PCT value is high and it's obviously suggesting a bacterial infection that may not be adequately controlled. Now, we don't really know where this particular patient is in their journey through your healthcare organization, but perhaps you want to have a more in-depth conversation with folks from your antibiotic stewardship team and say, look, are we really looking at the use of PCT and effective antimicrobial stewardship, something that is really important to organizations? And, you know, the mark on this type of thing changes frequently, so it's hard to get these types of initiatives going within EHRs where it may take a back seat to larger organizational initiatives. So if you can drive this type of change, and as Katherine was showing you, really change your KPIs and your organizational quality metrics and recommend actions like switching your antibiotic treatment, continuing to monitor your PCT, WBCs, and other clinical values like, you know, is this patient febrile? Do we want to consider discontinuing an antibiotic treatment as soon as possible? So being able to pull in data from multiple sources across this patient's journey through all of these different data areas really is helpful to transform the lab from just somebody that spits out those results in a manufacturing engine to something that is more supportive and contributes to the decision-making process. So then how do we evolve, right? We're looking at an example algorithm, again, of sepsis and PCT. And I realize that, you know, we can have a whole separate discussion about PCT, and I'm not here to talk to you about PCT use, and you can plug in lactate here in a similar algorithm and really anything you wanted to do. If you wanted to talk about coagulopathy or anemia, we can use very similar algorithms here and build them out very simply. So if I want to look at my PCT value, consider either initiating or discontinuing antibiotics and look at those recommendations and provide the recommendations that you're seeing down here in blue. So do we want to look at different diagnoses? Do we want to repeat a PCT? Look at the risk profile of this particular patient, and then do we want to continue to follow them and perhaps have an opportunity to discontinue our antibiotic earlier? Then if we want to look at another crucial disease state like heart failure and how we can really go ahead and augment our treatment pathways for that, we can do that with clinical values in decision support for heart failure and look at things like our patient's weight, our respiratory status. But if we really want to go in and take it to a whole nother level, we can look at Gallatin-3 and see how the particular patient, if they're looking like they're going to be somebody that is going to be at high risk for progressing down heart failure and decreasing their renal function, we can look at those particular values and perhaps have an opportunity to counsel them earlier if they're low risk. Or if they're moderate risk, do we want to get them into a long-term care management program? If they're high risk, do we want to go more intensively and perhaps readmit them or have a different discussion with their caregivers and how we're going to impact these particular individuals along the continuum of care? So at this point here, you guys are going to get a break from having to listen to me, and I'm sure you're thankful for that. And we're going to go in and have another survey. So taking a look at our survey here, we'll go ahead and give you guys an opportunity to respond to that survey. And then in just a minute, I'll go ahead and return to the last couple of slides, and then we'll give you an opportunity to ask some questions. Again, just to reiterate, what protocols or clinical guidelines is your organization trying to implement, and what role is the laboratory playing in this process? You know, and I think we'd probably get a pretty diverse group of answers here. I'll be really interested to hear everybody's responses, because, you know, some organizations out there, they're really doing a terrific job of engaging the lab, and they want to have much different conversations than folks that maybe they're those folks that are really trying to break through that wall that we talked about, and they're really struggling. I feel like sometimes I'm frequently struggling against that wall, and really I welcome those days when I feel like I can just smash through it and have good engaging conversations with folks like y'all. So I think we've given everybody an adequate time to respond to our survey here, and I'm going to move on. So we're just going to briefly talk about, right, characteristics of a successful product, of a successful project. And I really see this as an opportunity for us to talk about a successful product as all of these different data sources that we have, right? So if we look at all the different data that's available, to me, that really represents all of the different colors that we have here feeding our patient picture, right? We're pulling that all in, and you may have a disparate LIS from your EHR. Maybe your organization is even using a different practice management system. So how can not only the lab, but other individuals get a good picture of what's going on in the patient population here? We have some strategic imperatives, quality initiatives, and variability. We want to go ahead and look at organizational and financial risk to really then determine, is this going to be relevant? And so I'm going to pause here. I see that we have a question here as we finish talking up about the characteristics of a successful product. Excuse me, I want to say product all day today, apparently, and instead of project. And I'm going to pause. There was a question in regards to opioid management. Can it interface with states' PMPs? And the answer to that is yes. We can interface with prescription drug monitoring programs and help you to go out and query those particular systems. So it just really is going to depend on how your particular organization wants to handle that and where that's going to fall in the treatment pathways with your patient population. But I think, again, a great conversation, and as I stressed here with our data slide, really, we don't care where that data comes from, right? We can ingest it into the system and then build a particular rule for how we're going to handle your patient treatment. Okay, and then let's see. Very valid point here, and we have another question regarding the project slide. The feedback loop and area for improvement seems to be missing from the characteristics of a successful project. And I think that, you know, I would agree with that, but what we're trying to really get away from is really looking at it as just a single evaluation. It's a continual evaluation in the circle there. And so that's really what we're getting at with the evaluation of the successful project. Is it's an ongoing evaluation, but certainly we could add another element into our feedback loop there to evaluate that successful project. Thank you for the feedback. So again, how do we select priority initiatives as an organization? We want to look at particular internally identified projects and what are your quality teams doing there. Do we need to look at external organizations? And we want to make sure and choose wisely there. So, do we need to focus on Joint Commission and patient safety goals? Obviously, very, very important. And we can help you do that within the lab. Like we talked about, looking at particular metrics for, lactates or turnaround times. And how can you work with business partners like us to go ahead and move through best practices and proactively share innovations. So I'm going to pause here and see what other questions we have, and then we'll continue. So folks out there that have been very patient and waiting till the end for your questions and sort of really thinking up good ones, we'd love to hear it. So go ahead and just jump in there and ask away on questions. If you need assistance on where you can provide those, we'll certainly give that to you. So I'm going to pause.
Thank you, Todd, and Katherine, too, for your informative presentation. So yes, we will start asking some more questions. And as a reminder, if you do have any questions to ask, please do so now. Use that Ask a Question box that's located on the far left of your screen, and we'll answer as many of your questions as we have time for. Okay, so let's get started. Todd and Katherine, I'll ask it generally to both of you, and then whoever would like to answer, just go ahead and chime in. Okay, so let's start with this question. We've got several questions coming in. Let's see. Okay. My physicians already don't read the information the LIS provides. How will this make them pay attention to critical or new information?
Todd, I'd be happy to take that one. So thank you for the question. This is Katherine again. So physicians, we do hear this often when we're talking to partners. Physicians have a lot of information to look at. Is it going to be perceived as yet something else to look at? The information that is available and visible to physicians and other clinicians is not a separate screen. It's not something new that they have to go out and look at and pull from. So we're talking about including information that appears in the same place where their current lab results are pushed, but it's supplemented with information that's crafted by our individual hospitals and systems, and using physician leadership and involvement in that process. So if there's, for example, cardiology, certain clinical variability that's occurring now and noncompliance with certain pathways, or difficulty interpreting information that's coming over to them, the recommendation would be to work with physicians in that area to get consensus on it, and also to help develop what that messaging looks like, or at least have them look at that and vet it in advance so that they know what it is that their physicians are going to be seeing in those situations where the clinical variables apply. So it's not something new that they need to go out and seek or look at. It's a part of the same information that they're viewing. So this is generally perceived very positively, and it's not, oh, this is just another pop-up that I have to kind of work through. So we want this information to be meaningful and to be a part of their decision process and their evaluation.
Thank you, Katherine. Let's go with this next question. How do you assure that you avoid introducing alert fatigue when designing decision support tools?
So I'll take a pass at this one, Katherine, and then you can feel free to add info here. I think it's very important to address alert fatigue. We all know that that's a huge problem with physicians. And what we're trying to do, and again, configuring this solution, is design it so that it's going to meet your organizational specific needs. So if we want to add additional information, as Katherine mentioned, if we want to email or text other members of the team so that we can impact things at the point of care without impacting the physician workflow, we certainly have the opportunity. The key takeaway here is that we're able to configure the solution based on the organizational needs. Some organizations have had success with pop-ups, but others are like most across the country where they really feel like they're being bombarded, and so we want to deliver a solution that is going to be something that's going to be beneficial to the organization and not impact that workflow in an unsatisfactory manner.
Thank you, Todd. And let's see, a few more questions coming in. Can system help physicians interpret potential contaminated blood cultures? Now, this is a few parts. Can system help physicians interpret potential contaminated blood cultures? And can system provide guidelines for using antibiotics and what antibiotics to use? Have systems that have implemented the system used algorithm results as recommendations or requirements? And final comment in this question, foresee issue if patient is seen at various HC facilities in order for system to access data and make decisions.
I'll take this one. Thank you. And I can see it, thank you, Christy, in the to be answered questions. So I'm going to take this piece by piece and not necessarily in order. The answer to most is yes, but we'll break that up. So in terms of helping physicians interpret potential contaminated blood cultures, the short answer is it's easy whenever something's available in the LIS to be able to have that as a trigger. So as long as that's information that's in there that we want to highlight and provide additional interpretive information to the doc, we can absolutely do that. Can the system provide guidance for using antibiotics and what antibiotics to use? Yes, and I think earlier when Todd was showing the one portion of a sepsis protocol algorithm, there's some examples there in terms of basically a decision tree. And at what point in the decision tree do we want to push certain information that would help to provide that information? We can do so. And further, to kind of reinforce what Todd was just saying about the quantity of info that docs get and who gets information provided to them, an example there might be that maybe it's the recommendation goes to someone on the pharmacy team as well, or it's in two places. It's viewed in the information that comes through with the lab results, and it's also alerting a particular distribution list or team or texting members of the pharmacy team so they can see that information faster and make changes more promptly. The question about have systems that have implemented this used algorithm results as recommendations or requirements? Yes, that's part and parcel to what we're talking about here. So we're not approaching our customers and saying, here's new practice that you should be instituting. It's what are those practices that you already have in place or algorithms you want physicians to be considering and complying with, and that's where we start. That's where the recommendations and the rules that are built in the system begin, and and that's where how those are built around. So hopefully I'm answering that question. And I really like this last piece of the question. The writer has, let's see, go back to the answered ones. It says, I foresee an issue with, I'm going to paraphrase because I'm not seeing it in front of me, about, here it is, if patient is seen at various healthcare facilities in order for the system to access the data and make decisions. So one of the things that we did not highlight here is that really anywhere within the healthcare system that we can bring data into, we can use that to make decisions. So I have one customer that is talking about how patients receive testing at one hospital and then they might be transferred to the academic medical center, and concern about information being lost in translation there. But if we can make sure that we're including in the setup that all that information is available, we're looking at what setting that was. They were in setting A, and this is what the results are. They're now in setting B, whether that's transition to a different part of the hospital or a different setting of care altogether, outpatient to inpatient or one hospital to another. One of those data variables is what setting they're in. So we're able to look at that. So if we want to target patients in particular who are moving from outpatient to inpatient, or looking at one hospital to another, depending on what that algorithm is, that's anything that's a data element, we can use that as a factor, and it's not something that would be excluded. So at the end of the day, what we're talking about here is that we're not saying, well, we can only look at those patients that are inpatients. We can't look at anything outside of that. So it is within scope, and it's part of the process that we go through in talking to our customers about what problems they're looking to solve clinically and operationally, and we can include those data elements.
Thank you, Katherine. Now our next question, can the physician see the information about the cost of certain lab tests and where a reference lab test may be sent to?
So I'll speak to that. I think, that's certainly an option for an organization to provide a physician with cost information, but I do think that opens up a pretty big can of worms that may be difficult to deal with. But the alternative would be to make a recommendation to a physician that they haven't perhaps chosen the most effective reference lab for a send-out test, or that the fact that they've chosen a send-out test and in all likelihood the particular send-out may be able to be performed by Amber's Methodist Health System, for instance. So there is opportunity for us to address that, and Amber, if you don't feel that I've answered that question appropriately, then feel free to ask for some more insight there. But we can really help you to address not only your send-outs prior to send-out, but we can also look at your reference lab information and build a more complex interpretation and more detailed, usable information for those diagnostic doctors on your team.
Thank you, Todd. Now it looks like we have time for just a few more questions. Maybe we can slip one more in here. Let's end with this. Doesn't this increase the number of steps physicians have to take to order or interpret? Our physicians are already unhappy with pop-ups and number of applications. How is this any different?
Christy, I'm just looking, I apologize. I was looking at the answered questions, and so I need to get a better view of this so I can make sure that I answer that properly. So physicians, are there more steps? And I guess we could also say we want to make sure that we try to make physicians no more unhappy than they already are. So in terms of ordering or interpreting, I guess you could say with ordering, it might be an additional step, but that's only in those situations where it looks like there's inappropriate ordering, either over or under ordering that's taken place. And I think we've established, and most of us can agree, that guidance is something physicians are asking for. When it happens at the moment of ordering, sometimes that's not always good news, but what we've seen is that the vast majority of physicians want additional help and guidance in what tests to write. And partnering with physicians as an organization targets what areas to really go for first to create efficiency as well as reduce clinical variability. It's making those choices, picking which physician audiences, which clinical areas to begin with. Might not be sepsis, maybe it's related to coagulopathies, as we talked about, or maybe transitioning from one level of care to another. So there's lots and lots of options, and that's one of the reasons why we wanted to highlight that characteristics of a successful project. There's so many ways to use clinical decision support, and really prioritizing which ones make sense for your organization. And I know for Todd and I, that's the thing that we most enjoy, is talking about not just the tool, but how it can help our customers with what they're challenged with, and trying to help them talk through prioritizing so that these are valuable. And there's always disruption with change, but we want to do them in such a way that the physicians feel good about them too, because it can be demonstrated, look, we've cut down on waste, or we've sped up the process in these particular areas. So it's a part of what projects are selected. So, and in terms of, are there additional steps in interpreting? Similar, there might be. Similarly, there's additional information that's provided to help them interpret, and the ultimate goal is for them to feel better about the information that's provided to them. They may realize, oh, I don't have to do this additional test, or yes, maybe I do have to do another test. It's a part of the process in providing supplemental clinical information. So it's not a forced, you must do these, these following things, but here's the protocol as it exists that your department has endorsed, and here's more information to help guide you through the next steps. So hopefully that's addressed this in terms of, physician steps. I think we have talked before about pop-ups, and, as we've said that, if there are data elements and algorithms that the LNIQ CDS implementation targets that you want to feed into a pop-up in your EMR, we can do that. But we don't want, we want to make it perfectly clear that this is not our CDS solution is not a pop-up machine. And we want to make sure that we're judicious about not only what projects and challenges we help our customers to address, but also what's the best way to attack those individual clinical variability, revenue, or interpretive issues that they may have. Todd, is there anything you'd add on this one?
No, I think you did a wonderful job summarizing it. So I'll just be the first to say thank you, everybody, for tuning in. We appreciate your participation and hope that you found today's session valuable.
Thank you, Todd and Katherine. Now, do either of you have any final comments for our audience before we go?
No, thank you.
Thank you both again for your time today and for your important research. And we'd also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. I do want to also thank our audience for joining us today and for their interesting questions. Now, questions we did not have time for today and those submitted during our on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. At the close of this event, a survey will pop up on your screen. Your participation is appreciated, and your answers help improve our webinar program. Until next time, goodbye.